no place I'd rather be. Yeah. There's no face I'd rather see. Before you count 1, 2, 3, yeah. I'll be there when you call on me, me. Closer to my heart. There's so much you mean to me. I hope that we will never part. Oh Kenya, when I'm in you I feel free.
This land is filled with so much treasure.
In this love without measure. Oh, where the rivers meet the sea. Kenya, welcome home, 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 home.
Twende basi, take me Masai Mara, ama twende Amboseli. Let's go Savo Safari, want some elephants in trouble. We can take a walk on the Wise and Kilifi. Tunywe Tusker na marafiki, nyama choma na sukuma wiki. Twende Kisumu tusikize mziki. This is the land of champions. Famous actors and runners. When the night falls and the stars come out, you can hear how the lions roar, 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 roar. This land is filled with so much treasure.
And this love without measure. Oh, where the rivers meet the sea. Kenya, welcome home, 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 home.
When you're stuck in the savannah and you're surrounded by leopards, hakuna matata.
When you're caught on traffic and you're late for your next flight, hakuna matata.
When you're feeling so low and your moods are down low,
Hakuna matata. Hakuna matata. Karibu Kenya, welcome home.
Hello everyone. Karibu Kenya. Welcome to Kenya. My name is Irene Chami and I am Director Programs at the N Fund. I joined the N Fund over 3 years ago. From my time here, I have seen firsthand the tremendous efforts our staff, partners, and investors, literally everyone, have been doing to help close the book on neglected tropical diseases for communities in Kenya and around the globe. The N Fund is a collaborative philanthropic initiative that supports countries reach their NTD control and elimination goals, for which 1.6 billion people are at risk worldwide. We started working in Kenya in 2012, and since then, it has been a priority country for us. Approximately 25 million people in Kenya live with one or more NTDs, and interventions are needed for 5 of the 6 diseases that the N Fund supports, such as intestinal worms, bilharzia, lymphatic filariasis, also known as elephantiasis in its advanced stages, river blindness, and visceral leishmaniasis. While their names may not sound familiar, their symptoms are well known to all of us. Young bellies full of worms, stunted growth, irreversible blindness, swollen limbs, and excruciating itching that causes severe pain and disability and even death. All these from diseases that can be treated and eliminated. In today's webinar, we hope to provide you with an overview of the country's NTD program and the important progress being made against its elimination goals. The achievements you'll hear about are the direct result of many years of partnership and collaboration. Each of today's speakers represents a vital stakeholder in the NTD landscape. both at the national and community levels, who have all been working tirelessly toward one goal: to beat NTDs once and for all. This type of multilateral, multi-sectoral cooperation makes the NFund's model unique and successful, and it will not be possible without private investments, another vital piece in the quest to end NTDs. Thanks to private investment, the NFund has been able to strategically dedicate resources to strengthening the capacity of our partners in Kenya, filling gaps in program implementation, and supporting the Ministry of Health in making progress on its national goals for NTDs. To everyone watching here today, thank you so much for your support and partnership. We are deeply excited to welcome you on our virtual trip to Kenya and hope you gain a new or expanded understanding of NTDs in Kenya, an appreciation of the various partners we work with in the country and how their expertise are leading the path of disease elimination history, and of course, excitement for our collective vision of a country free from NTDs, not only in Kenya, but in the 30 countries we work in around the world. Thank you and wishing you a safe and memorable journey through Kenya. Asante sana.
Karibu, Kenya. Allow me to tell you more about the place where breathtaking landscapes intertwines with a vibrant, diverse culture that many of us call home. But beyond its beauty, Kenya is a country defined by resilience, innovation, and community. Let's start in Nairobi, the heart of East Africa's largest economy. Known as the Green City under the sun, Nairobi blends modern life with deep-rooted traditions. Nairobi is the only city in the world with a national park. It's home to the innovative tech scene that we call the Silicon Savannah, where groundbreaking solutions are born to address challenges faced across the continent. Kenya is made up of over 50 million people, representing more than 40 ethnic groups, each with distinct customs and traditions. This diversity is the foundation of our strength as a nation. From the shores of Lake Victoria to the towering peaks of our mountains, Kenya's natural beauty supports life and sustains livelihoods. Agriculture, particularly our tea, is not just a part of the landscape. It plays a crucial role in the economy, providing income for countless families. Food here is more than just sustenance. Our national dish, ugali, is a staple that connects Kenyans across regions, while coastal and lake-based cuisines tell the stories of communities through every bite. While Kenya is famous for its national parks, wildlife, and marathon legends, it's also home to communities that coexist harmoniously with nature. These are the places where NGOs and investors work hand in hand with local communities to address critical issues like education, healthcare, and sustainable development. Kenya is a nation of many faiths, where unity in diversity is celebrated. Whether through the languages that we speak or the faiths that we practice, our country is defined by the values of community, peace, and collaboration. We welcome you to engage deeply with Kenya, not just as a place to visit, but as a country of opportunity, growth, and shared purpose.
Hello, everyone. Karibuni, Kenya. Welcome to Kenya and welcome to our 4th annual Journey Through webinar. My name is Carol Kutsushi, and I am a Senior Associate to the Vice President of Programs at the NFund. Here with me to kick off our very vibrant discussion about Kenya's efforts and progress to eliminate neglected tropical diseases is Wycliffe Omondi. Wycliffe is the head of the Vector-Borne and Neglected Tropical Diseases Unit at the Ministry of Health in Kenya. Wycliffe, thank you so much for joining us today, and karibu sana.
Asante, thank you for your invite, and we look forward to an interactive session on our journey towards elimination of neglected tropical diseases in the country.
Thank you. Thank you. It means a lot to have your perspective as head of the Vector-Borne and NTD unit. And so to start us off, I just wanted to ask you if you can kindly tell us about the Ministry of Health and its role in coordinating the NTD programs. Just tell us a little bit about the kind of work that you are doing at the national level, at the Ministry of Health, in terms of the nation's public health.
Thank you for the question. The Ministry of Health is one of the agencies within the broader government tasked with improving the lives and livelihoods of the Kenyan citizens, looking at broad array of diseases that impact on humanities. The role of the ministry in neglected tropical diseases, if I can provide summary, is again linked to the overall objective or goals of the ministry. One, by providing key policy guidance to the whole nation on issues of control and elimination of neglected tropical diseases. Secondly, the program through the ministry ensures that the sub-national teams are capacity built through adequate training on issues of vector-borne and neglected tropical diseases, and the training looks at how are we able to prevent, how are we able to treat, how are we able to look at, assess the impact of the interventions that we are doing. Another key role of the ministry through the program is to provide the technical assistance to the sub-national teams of the counties in the provision of the various interventions that we conduct, either be it mass drug administration, be it morbidity management, disability prevention, be it surveys, or be it community awareness forums to try to prevent the people to prevent themselves. Lastly, I can say that another key function that the national ministry through the program does is to manage the referrals from the sub-national levels. And these referrals, we provide technical expertise at different county levels when they encounter challenges of NTDs. So in brief, that is the main role of the ministry and the program in coordinating elimination of neglected tropical diseases in the country.
Well, thank you for sharing that, Wycliffe. And I'm curious, what made you want to work for the nation's public health? You know, in briefly, just tell us about where did this passion come from?
It's a long story. The background I come from is one that is riddled with a lot of disease burden. Seeing community that is battling diseases gives you that kind of inspiration on what am I able to do to contribute to the problems that the society I grew up was living in. So one of the key elements within the area I grew in was malaria. And of course, not only malaria, there's a number of neglected tropical diseases from where I come from, schistosomiasis, intestinal worms, scabies and other ectoparasites such as jiggers. Of course, the list is endless. So growing up in such a background where you see you're not able to make ends meet because of ailments gives you the inspiration. What is it that I'm supposed to do? So that is how the thought process of embarking on public health was birthed when I was growing up.
Wow.
Burden of
It
the
comes from
diseases.
a burden of the
Yes.
diseases and comes from the experience that you went through as a young boy. Wow. For more than
Very
10 years, Kenya has made extraordinary progress in efforts to end NTDs. Please share with us some of the greatest programmatic milestones you've seen, and similarly, some of the challenges that you've seen as well.
Indeed, for the last 10 years, remarkable progress has been made in not just control but elimination of NTDs. Some of these greatest milestones we've marked was the country being declared free of guinea worm in the year 2018. So it's not a mean feat. It is one of the feathers that we wear proudly, having eliminated at least one neglected tropical disease. Nonetheless, there's a queue of other neglected tropical diseases that we've made tremendous inroads towards the elimination. So just to enumerate, we are at the verge of being declared free of human African trypanosomiasis. We've submitted our dossier to World Health Organization, which received minimal corrections. Those minor revisions when made, I think in the near few months, we'll be declared free of another NTD. Nonetheless, we've also made inroads on the field area of onchocerciasis or river blindness, which when we put our interventions in place, we are only counting maybe 2 years for us to be verified free of river blindness. But I want to cycle back to some of the milestones where a number of interventions have been done. One such key disease area is lymphatic filariasis that have seen progressive administration of mass drug administration in the coastal region from the year 2002, but collapsing around 2011. So in the past 10 years, with support of partners such as NFund, we upscaled this intervention. So for the last 10 years, the lymphatic filariasis have seen tremendous significant improvement in terms of not just meeting the minimum coverage, but exceeding that in all the implementation unit. I'm citing this because it is a challenge. If you don't meet the minimum coverage, then you are not going to be validated or may be able to lower the threshold. So for the past 10 years, we've maintained above the minimum coverage in these areas. And it is not just above coverage. The surveys that we conduct to monitor have equally validated this, and we've seen tremendous reduction in the prevalence of lymphatic filariasis below public health importance for the last few years. And if we were to go to the wire, we can say that we are free, but we are not free until you follow the late regulation. So that's another key area. So same to blinding trachoma. So those two NTDs, probably by the year 2028, 2029, we'll also be celebrating validation free of those two, which is not a small milestone. It is great in terms of what the program has achieved. Of course, a number of challenges still exist. One of the quickest way to reduce the prevalence is through giving mass drug administration. but it's not the only way. So there's a challenge in still ensuring the coverage of water sanitation and hygiene in these areas that have achieved this tremendous success. We also have issues of behavior change, communication amongst these endemic areas, and of course, a number of partners are also still trying to pull their own activities in different ways, so coordination issues also crop up. So in summary, those are some of the key milestones the country has witnessed in the last 10 years, and probably some of the challenges which I believe moving forward will be able to overcome.
Amazing work being done, and indeed we celebrate those successes. And lastly, we would like to hear from you what you think about ending NTDs in Kenya. What will it mean for this country and the lives of its citizens?
For me, what ending NTDs would mean, it would mean that the communities who have been impacted by these diseases would be now free from the burden that is inflicted by this disease. I'm saying this in terms of seeing what is our source of livelihood in Kenya. So they will be celebrating healthier life, but also become more productive. So that's my vision. Ending NTDs means a more productive citizen, and being more productive simply means, I'm saying this again because the white collar job or blue collar jobs that we are looking for are diminishing in a high rate. So most of us live either through doing agricultural work or doing some businesses. Having these NTDs impact you from that daily. These are daily activities. So if I have an NTD, it keeps me from that. That means it impacts me. So no healthy life, betterment of you economically is also lacking. So for me, ending NTD will bring more healthier life and will bring more money into my pocket. And of course, when I have more money, I'll have I can have a choice on what I eat, a choice on where I want to go, and a choice on what I want to do. So that is what I see the lives of the citizens when we end the NTDs. Lastly, when we end the NTDs, we'll be able to concentrate on other critical diseases that are not likely to be eliminated through available interventions. So that is what I look at the end of eliminating NTDs that are endemic in the country.
Oh, I could go on and on and on because it's very interesting to see the milestones that have happened and the work that you're still doing at the ministry. And we just want to say thank you so much, Whitley, for sharing your insight, your experience, and giving us a glimpse of the extraordinary work being done to make NTDs history in Kenya. Now, as we continue our journey through Kenya, we are going to take a brief trip to Lamu Island, where we will see how one county is supporting those impacted by advanced stages of lymphatic filariasis, also known as elephantiasis. Thank you and safe travels.
Angalia mwenye madende, kwambia mwenye midende.
Mimi naitwa Faiza Sheikh, ni afisa wa afya kutoka Lamu, na mimi pia ni msimamizi wa magonjwa yaliyosahaulika yakiwemo magonjwa haya ya matende ama na mshipa wa kushuka. Na leo tulikuwa tumekuja kukutembelea ili tuweze kujua na kufahamu huu ugonjwa na kuona kweli ugonjwa uko na watu wako na wanapitia hali gani na changamoto gani, ili tuweze kujua tutasaidiana vipi.
LF are initials for lymphatic filariasis. Lymphatic filariasis is a disease caused by thread-like worms, long and slender worms that live in the lymphatic vessels. So when you look at the life cycle, there's a mosquito at one point and a human being. So the mosquito bites an infected human being, picks the baby filaria worms that are circulating in the blood, we call them microfilaria, and then they develop in the mosquito for about 2 weeks, roughly 14 days, and at the end of 14 days, they are ready to become infectious. The retention of the lymph fluid is from blockage by many worms. That's what causes the swelling, because the lymph is not flowing freely as it should.
Ndio nilipokuwa nimefika umri kama miaka 15, 16, ndio kachukua na homa kali. Ni homa gani? Lakini kali sana. Kalala, nilipoinuka siwezi kwenda. Hapo huku shina la choke likundu kama damu. Basi kawa enda kilukilia. Ndio saa ile kama mwezi miwili wana nimeshuka, nimefura sasa. Basi lakini kama mkana nguvu za ujana, sio? Sifikiri lolote. Nenda na shamba yangu na chukuchu, kama sikia chukuchu. Basi kawa nenda na mzee wangu tukifanya kazi na mai kivuka mai yavua. Nilikuwa nataraji kufanya kila jambo kwamba kuisaidia mimi na kuwasaidia wazazi wangu. Lakini baada ya kupigwa na ugonjwa ukanifanya kama mkichea.
For LF, once a person has contracted the disease, the parasite, the microfilaria, they stayed for quite some time before the symptoms appear. And once the symptoms occur, it becomes like too late. For the lymphedema, it's non-reversible. You cannot reverse the leg. Once it's swollen, it's swollen.
Hawalitibu kwa ina matabibu wa Kiswahili. Alikuwa kanifanya kibemele kawachumia kwa takhfifu la homa. Lakini hainishiki kama huko nyuma. Ile kwa mbenchu hafanyi nini na katoa shukrani.
I just wanted to give back to my community in terms of health because from the place where I was born, the facilities, the in charges, the nurses, everyone was from outside my community. So I really wanted to help my community, like me being there.
I think we are almost there. I believe I'll see the end of LF in Kenya in my lifetime.
Hello, everyone. Welcome back. Here with me is Michael Ofire. Michael is a program officer at AMREF. Michael, thank you so much for joining us today during this busy time of the year. AMREF has been very critical as a player in the NTD space and a valued partner of the End Fund for several years now. Before we begin, maybe you could tell us a little bit more about AMREF.
Thank you very much, Caroline. AMREF prides itself and works with various development partners, including the End Fund. The organization, founded in 1957, started off as a team of flying doctors providing emergency evacuation services. And over time, the organization has grown to right now having operational presence in over 10 countries in Africa, fundraising offices in Europe, the United States, and the organization is constantly striving to grow its portfolio of programs and transitioning from an implementer to providing technical assistance and support to various governments, whether national or devolved governments across various countries.
Wow, thank you so much for that intro, Michael. Allow me to ask you, what made you, as Michael, decide to work on the control and elimination of NTDs?
Yeah, thank you very much. So neglected tropical diseases is not a very lucrative areas that most people, working in the global health and public health sphere focus on. But, there has to be a group of individuals, like-minded individuals that are constantly thinking of challenging status quo. I pride myself to be one of those individuals that are constantly striving to work with communities living at areas that, some of these neglected tropical diseases like elephantiasis, intestinal worms, bilharzia, Kalaza, and many more. And most of these areas are areas that are predominantly, inhabited by poor communities, people that are unable to afford healthcare. The cost of treating neglected tropical diseases is not cheap. For instance, if someone requires surgery, they require up to approximately $400 for corrective surgery. Some of the conditions like elephantiasis, when they have swollen limbs, they require to, some of the topical creams and the ointment that they need to ensure they have. They're not very cheap. That will be approximately $15, a month. And some of them, based on their socioeconomic status, are unable to, afford some of these required medication. Look at, treatment of Kalaza, for instance, yeah? It requires approximately over $1,000 per patient. Medication that's required for approximately 17 days for them to cure is a bit expensive, and they're unable. So I pride myself to be people within the global health space, public health, that are constantly thinking about these communities and working with allied individuals to see how we are able to address some of their health needs. Thank you.
Wow, thank you so much, Michael. That is really commendable. We just saw a video about lymphatic filariasis in Kenya and the impact advanced stages of this disease can have on one person, one family, and one community. Can you share more about the work AMREF is doing to support patients with lymphedema and the hydrocele surgeries being conducted in the coastal regions?
Yeah, thank you very much, Caroline, again. So first of all, I just want to communicate to the communities out there, to anybody who is listening to me, that there is hope. The world has moved from a situation whereby it never knew how to address some of these diseases. But as we speak, we have preventive medication that can be provided to communities living within areas that subject them to be mostly at risk of diseases like elephantiasis. And for those that, unfortunately, for one reason or the other, when we were not providing preventive medication, they got the disease and now they have developed hydrocele that affects the scrotal region, or they have a swollen, leg or arm or breast for the females. We've been working with various governments at national and sub-national level. Our role is to provide technical support and capacity building, not creating parallel systems, but working within existing structures to try and resolve and meet the health needs of people afflicted by elephantiasis. So over the years, we've been able to work with various surgeons, capacity build them, and they're able to provide surgery routinely. We've so far at least, provided surgical intervention for over 1,000 individuals. And the impact of this is that they're able now first to go back and reintegrate within their communities. It helps them destigmatize, because these diseases are stigmatizing, especially elephantiasis that would affect your scrotal region. Some think it will then make them not have, families anymore. They think that it would lead to, infertility. But we've seen cases where after surgery, some individuals that still want to get more children are able to get children, and their families are happy and growing. For those that have swollen limbs, we are working progressively to capacity build them and train them how they're able to provide limb care, clean their limbs, apply topical creams to avoid secondary infections, sometimes bacterial or fungal. And over time, this helps them to improve their quality of life.
Wow, it's so encouraging to see that there's hope amidst all that the communities have to go through. In addition to lymphatic filariasis, AMREF is working with the End Fund on controlling intestinal worms and schistosomiasis. Please share with us more about the importance of deworming. How is it different from all the other programs that you are implementing currently at AMREF?
Yeah, so for deworming, first of all, the difference is at AMREF, we first look at how the disease transmission occurs, what is the source of infection, and then the next question we ask ourselves, and we invite other stakeholders as well to sit with us and trying to understand, now that we know how the disease is spread, what can we do to ensure that we break the cycle of transmission, or we prevent future generations from, some of the worms like intestinal worms and, bilharzia. So with that, we usually provide preventive medicine, provided, treating all at-risk individuals, and we usually target an annual 5 million people in Kenya, treat them, and with two medicines, one that will target intestinal worms, the other one bilharzia, and essentially also add other complementary interventions like water, sanitation, and hygiene, which are critical components in ensuring that the gains that we make when we provide preventive medication, at least you're able to sustain them through ensuring provision of safe water, train them on proper sanitation and hygiene practices, because we understand how the disease is spread. And so if you're also able to take care of some other social behavioral activities, like, preventing or educating community members on the importance of having latrines where, they would go and, use when they need to use them, so that they avoid, excreting in water sources that they still require for domestic use.
That's fantastic. It's so encouraging to see that you have those complementary interventions. So the community is also involved in all this, and it's long term. It's not just something you come in and do and then you leave them. And the fact that you also do capacity building so that they can be able to take care of themselves, that is very commendable. In all the programs AMREF is conducting, there has to be a lot of interaction and consensus with not only various levels of government, but communities as well. How has engaging with communities and government leaders at the country and national level been critical to the success of your work?
Yeah, so thank you. So AMREF in itself prides itself in strengthening primary health care. And at the center of this is the communities that we work with. And these communities, are prone to various diseases, including neglected tropical diseases like elephantiasis, bilharzia, soil-transmitted helminths, and chalazar that I just talked about earlier. And one of the things that we usually strive to understand are the social determinants of health. And this is about the people. Once we understand, what are some of the behavioral factors that, put them at risk, what are some of the environmental factors, Now we merge and bridge that with the biological risk factors that at times these communities have no control over. We try invite various stakeholders, experts, researchers, research institutions. We invite them on the table, including policymakers at subnational level and the national level governments, and try and answer some of these questions. And over time, that is what has shaped our interventions and our decision to also focus on neglected tropical diseases at AMREF. And we've seen over time, I think Kenya is approaching elimination for a disease like elephantiasis, moving from a situation whereby over 4 million people annually require treatment to right now we're talking just approximately 5,000 people. And of course, providing, other complementary interventions like those that require surgical interventions, working with the various subnational governments to ensure they can access surgery, and those that require to, manage their limbs, just work with them to ensure that we prevent disease progression, especially in cases of elephantiasis.
Oh my gosh. Okay. It's really amazing to see the numbers, and how there's been that reduction, and the importance also of collaborating with other stakeholders and of course the Ministry of Health. Lastly, I'm curious to know, what is your vision of the future? What is your vision of the future in line with the work that you're doing at AMREF? What do you envision?
Yeah, the vision for the future for me is inviting various stakeholders that are in this webinar. We have no one solution that would address, the health needs of these communities that are at risk of neglected tropical diseases. But I'll invite them, researchers, donors, the private sector. We all need to be in the business of addressing the burden of neglected tropical diseases. And this is an area that is our best buy-in in public health. Imagine a situation whereby 4 million people required preventive medication, and just providing them with the medication for around 5 years, reducing that to a situation where you're talking of approximately 5,000 people. And in the next 1 or 2 years, then we'll be saying nobody requires medication, for instance, for elephantiasis. So these diseases that we can do away with, like neglected tropical diseases, we can eliminate them so that the resources can be freed up to take care of other diseases that are still resource intensive, but we have to learn how to live with them.
Indeed. Well said, Marco. Well said. And I think this is also a way of encouraging us to reach the last mile. And thank you so very much, Michael, again, for taking the time to share with us so passionately about your work and what you do at AMREF and the reason why you are doing what you do. Well, before our next interview with AIHD, we're going to watch a video on the impact of schistosomiasis and intestinal worms and the importance of deworming for generations today and generations to come.
I'm a fisherman, like my father was. I spend most days on the lake. We depend on these fish to support our families. But a few months ago, I felt tired and my stomach hurt. When I went to the bathroom and saw blood, I knew something was wrong. I had schistosomiasis, spread by parasites that live in freshwater snails. The parasites leave the snails and then latch onto humans when we come in contact with contaminated water going through our skin. A healthcare worker visited our village and explained Each time someone with schistosomiasis urinates or defecates in the lake, new parasite eggs are released and hatch, and the cycle starts again. The healthcare worker gave me medicine that kills the worms. After just one dose, I have more energy and the pain is gone. I can sell more fish at the market and continue using the lake to support my family.
Hello, everyone. Welcome back. Here with me on the final stop of our journey through Kenya is Dr. Mary Amuyonzu Nyamongo, the technical advisor of the African Institute for Health and Development, AIHD, based in Kenya. Dr. Nyamongo, thank you so much for joining us today, and karibu sana.
Thank you very much, Carol.
To start us off, can you tell us a bit about African Institute for Health and Development, AIHD, and what made you decide to work on the control of elimination of NTDs?
So the first question on African Institute for Health and Development, we established this organization in 2004. I was the vision behind it, supported by a few friends. The institute was registered as a non-governmental organization in Kenya in 2004, 20 years ago. We actually just celebrated our 20th anniversary. And the main aim for establishing this institution was to allow African institutions to address African problems and working with communities to ensure that we provide opportunities for people themselves to craft interventions that fit their needs and address their problems. So that is the vision. In fact, our vision is empowering communities for betterment of their health, so that the communities are key and part and parcel of the intervention agenda. And so for 20 years, we were keen to integrate project research, project programming, research, and policy work, so that our research informs programs and those inform policy formulation in Kenya. And we've seen various inroads in that. And over the last 20 years, we've worked on neglected tropical diseases, non-communicable diseases, poverty, sexual reproductive health, gender-based violence, a whole range of issues that really affect our communities. In terms of our journey on NTDs, it's a long journey. I first worked on lymphatic filariasis in 1989 as an employee, a research officer with the Kenya Medical Research Institute. And that was also part of my PhD program in Kwale County. I was basically looking at community perspectives, community participation, understanding perceptions of communities towards lymphatic filariasis. And over the years, I've worked on onchocerciasis. I served on the African Program for Onchocerciasis Control as part of the Technical Consultative Committee. I have served on the WHO Regional Program Review Group for NTDs, WHO Global. I served on their various NTD committees as a temporary advisor. So over the years, over the last 35 years, I have worked at various levels. But the most, for me, fulfilling engagement is our current engagement in Kenya, where we see Kenya as a country working towards the elimination of some of these conditions, being part and parcel of the strategy conversations in this country, being part and parcel of the decisions around how to accelerate elimination of some of these NTDs. And so at a personal level, that is one of the most fulfilling engagements within the NTD space currently. Yes.
Thank you, Mary, for sharing that. Wow. First of all, congratulations to AIHD on your 20th anniversary, doing such great work and impact in the communities for the last 20 years. We just saw a video about deworming in Kenya. Can you share more about the work AIHD is doing to support communities to protect against intestinal worms and schistosomiasis?
So I will respond to that question first by reflecting on why Kenya as a country in 2024, we are still grappling with schistosomiasis and soil transmitted helminthiasis. Schistosomiasis, because I work in the space of advocacy, communication, we tend to try to use terms that communicate and people understand. So we use bilharzia in Kenya most of the time in our communication. Also kichocho. Kichocho is the Kiswahili word. Now that you're working through a journey in Kenya, kichocho. So I hope several of you remember that as we go forward. And then soil transmitted helminthiasis, intestinal worms, but the term we use mainly is mignon. Mignon is a hygiene disease. Water, sanitation, and hygiene. 2024, as a country, we are still addressing this as a key public health problem. I think there's a mismatch here. And when I talk to my friends and they ask me, why are you in this space? I just feel dignity is important. It's part of our constitution. It's part of our commitment on sustainable development goals. And for children and women not to have access to proper sanitation is just not acceptable. And so back to what we do on these diseases. In 2021, we started partnering with the NFAT on schistosomiasis and soil transmitted helminthiasis, mainly for the African Institute for Health and Development. We work on this social behavior change communication, social mobilization, where our focus is understanding communities, understanding the factors that may be sustaining these conditions, and working together with the communities to address some of those barriers. For instance, cultural factors, not sharing toilet facilities, hand washing when you after toilet use or before eating, beliefs around what causes these diseases, schistosomiasis, for instance, in the Lake region, and other beliefs around sick children who are sickly, culturally, their beliefs regarding what the etiology of that condition, those conditions. So basically, the AHD's approach is understand the context, work with the communities to derive interventions and implement the interventions together. We work closely with the Kenya WASH Alliance because WASH is a key challenge in communities where these two diseases are endemic or co-endemic. And therefore, activities around construction, proper use of toilet facilities, hand washing, etc. are areas where we've been working with. In terms of perspective, as a woman, I really, it worries me that as a mother living in a community without access to a toilet facility, and you have children around you, you have men around you, we really need to bestow dignity to communities. And that's why I'm personally, and as a technical advisor to the AHD, we are very committed to ensuring that we sustainably control these diseases or ultimately eliminate them.
Clearly, there's still a lot to be done. And I know the importance of your work in the communities and how important it is for you even to have other stakeholders to help you in achieving your goals. In this work, who does AIHD partner with to raise awareness of these diseases, and why is it critical in the success of deworming campaigns?
The factors that sustain these conditions are multifaceted, and so no one entity is able to address these conditions. And therefore, the Ministry of Health has really expanded its reach by bringing on board donor partners. NFund has really played a key role in the last 3 years in this country in terms of supporting institutions to address these conditions in a sustainable manner. We have the Ministry of Health itself, because it provides the policy, the strategy, the capacity to deal with these conditions. Being a decentralized nation, the county governments are key and critical. Implementation of health is within the county governments. Also, other partners, for instance, under the Deworming Innovation Fund, we work closely with AMREF and the Kenya Wash Alliance. Within the ARISE, which is the Accelerate, Resilient, Innovative, Sustainable Elimination of NTDs, we work with other partners. But most importantly for AIHD, the community is our key partner. And if communities own the programs, if communities run with them, we are able to see sustainable and evident change in the disease trajectories. So the community health promoters are critically important to us. They are the face of Ministry of Health at the community level. They interact with the communities on a daily basis. They know the households. So those are our key partners. We also currently work with change agents, maybe retired teachers, retired nurses, influencers at the local level who have rapport at the community level to engage people on a continuous basis. We also work with, of course, the county government, the health promotion officers, the disease surveillance officers, and therefore we work with a whole range of people at the operational level. Unfortunately, I would want to say that we haven't been effective in bringing the private sector on board. And for infrastructure investments, such as investments in water, in latrines, we understand the need to bring in partners who are able to invest in boreholes, in water tanks, in trunking of water to households. And so that's an area of need. And in the next 2 years, this is a partnership that we really need to focus on as we move forward. Also, in terms of the resource mobilization at the county level, these are areas that we feel we need to do more on as we move forward.
For sure, there's a lot still to be done. Even in this, in this moving forward, like I can see there's still a lot of work to be done. But in addition to intestinal wounds and schistosomiasis, you work with the End Fund on onchocerciasis, which I know is one of your passion, river blindness mapping. What is being undertaken for this mapping, and why is it important for Kenya to declare disease elimination?
Yeah. I'm happy that we are now working on onchocerciasis in Kenya. I've been involved in the onco activities since 1999, when I started engaging with the African Program for Onchocerciasis Control. And Kenya is suspected to have eliminated onchocerciasis in the 1950s, when there was a lot of vector control activities, and further studies, subsequent studies have shown that Kenya may actually have eliminated onchocerciasis. And the rapid epidemiological mapping of onco done by EPOC established that Kenya was hypo-endemic for the disease. However, for us to be certified to have eliminated the disease, we need to undertake specific studies, do exclusion mapping, for instance, do some epidemiological assessments, entomological assessments, where we're looking at the black flies. If they are not there, if they're there, are they able to transmit disease? And so this is the process the country has engaged in. We also have had several consultations at the community level with experts, and the preliminary results indicate that Kenya may have eliminated the disease. And so for us to be certified by WHO, we really do need to document the historical aspects, what we are doing now, the studies, and then apply for certification of elimination. And as a country, we are at a good place to do that. So in 2025, we hope to finalize the dossier that will then be submitted to WHO headquarters. But in the meantime, we work very closely with the WHO country office. Big up to Dr. Joyce Onsongo, who is a real key supporter of this process. And at the WHO Afro region, Didier Babajika, who is our partner there, we really are trying to ensure we do due diligence, we undertake all the required assessments so that the country can be certified to have eliminated the disease. Really, as a country, we look forward to this day when WHO will pronounce elimination status to the country.
Indeed, that is something that we all are looking forward to. And Mary, as it is normal for any project or program, there are always successes and challenges. Could you please share with us some of the successes you've seen in your work and some of the challenges you've had to face?
Within the NTD space, maybe just confine this conversation to that. One of the key challenges in health interventions is coordination. And over time, you see different organizations doing different things, sometimes working at cross purposes. Over the last 3 years, we've seen the Minister of Health bring us together, coordinators, so that we can share resources, we can co-plan, co-create some of the activities. For instance, currently the AHD, AMREF, DNDI, Site Savers, we are all working together towards this elimination goal. And therefore, the resources are not infinite. There are challenges with that. So bringing our resources together and thinking through what we can do going forward. I think over the last 3 years that I've seen that coming together. The monitoring and evaluation data aspects have really improved. Currently, we have some of the NTD indicators on the Kenya Health Information System, and I think this is a real achievement for the program in Kenya. Supply chain issues, requisition for drugs, a reporting back, reverse cascade. We've seen real growth again in that sector. Most importantly, I think for AIHD, when we started working on issues to do with advocacy, communication, social mobilization, they were not core to NTD programming. But now every program begins to think, how do we ensure that we transfer ownership of this project to the counties, to the communities, to the people themselves? And we've seen this become core to the interventions, something that I think is important because it actually communicates, we acknowledge the role of communities. We acknowledge that people are important. We acknowledge that people are the center of this program. And we've seen that go on, increase and improve over the last 3 years. And we look forward to having some of these activities really being implemented by communities themselves. So from the success side, we've seen that again on the MDA platforms, we've seen an uptake, 80%, 85% uptake of treatment by communities, which is actually a key indicator to potential for us to eliminate and sustainably control these diseases. In terms of challenges, I think one of the key challenge for the country is sustainability. A lot of the activities we undertake on NTDs are donor reliant. So the donors donate the drugs, most of them. The donors help us distribute the drugs. This is not sustainable. We do need to see budgets within the national government, the Ministry of Health budgets, within the county budgets. We need to see budgets allocated and utilized for NTDs, not just allocation, but utilizing then those budgets for NTD activities. That's the only way we can sustain these activities. Secondly, and I mentioned this from AHD side, how do we engage very effectively with the private sector? Because they have a role to play. Over the years, this is an area of need, and hopefully in the next 2 years, we'll see a lot of movement in that area where private sector really invest in NTDs in this country.
Thank you. And I'm happy to see and to hear from you rather that we have quite some good progressive steps that have been made despite the challenges. But right now, I just want to ask you, Mary, what is next? What is the next goal for AIHD, and what do you need to achieve your goal?
An interesting question. I think for AIHD, we've celebrated 20 years. During this celebration, we launched our strategic plan. The AIHD has grown in the last 20 years in terms of the range of partners, range of programs, but we are still, our presence is in Kenya. We've implemented activities through partnerships in other African countries. But to leave the Africa in the name, we really do want to expand this to other African countries. Secondly, we are still very donor dependent. So as an institution and within the strategic plan, we want to see how we can resource so that we are also able to define areas of work. If you remember, I indicated that we are very committed to working with the communities to help them solve their problems. So relying on external support doesn't allow us to be innovative the way we want to do or to address issues that we feel need to be addressed. So if we can raise resources that we can then channel towards supporting communities in a meaningful way, even as we work with our other partners in this. So that's the second area of need. Also, basically, to beyond the NTDs we are working on, there are other NTDs that we've not really touched on. Why should we in 2024, Carol, be dealing with jiggers? Really? So that's an area I think also we need to turn on. How can we then work with these communities to ensure that we understand the context and address those issues? So in the next 5 years, we have a robust strategic plan, and we call upon our friends and partners to join us as we expand our reach and as we meaningfully engage with communities to solve some of these persistent problems. Yes.
Wow. Thank you so much, Mary, for sharing such amazing work that you're doing, the challenges that you're facing, and even coming up with solutions of what we can do in the future. And thank you for teaching us two Swahili words, Minyo and Kichocho.
Thank you,
Thank
Carol.
you
but
very much.
Move forward, I think my parting shot is that communities are resilient. Communities understand their problems. Communities have solutions. And sometimes what they need is just facilitation. And that is our commitment. Thank you very much.
Well said. Well put. We are deeply inspired by all that you do, and we are really grateful as Enfant to partner with you. Everyone at AIHD, at the AMREF, and of course the Ministry of Health. And our biggest thanks goes to all of you who have been watching. This is the end of our webinar. Thank you so much for staying with us through the webinar. From all of us at the Enfant, we want to say thank you for taking the time to join us on this journey through Kenya, where I hope you are able to get a glimpse of our beautiful country and get a deeper learning on what is being done to help control and eliminate NTDs. We are so close, and we will go further together because we will be the generation to end NTDs once and for all. From all of us here, goodbye.